All right, everybody.
Hello and welcome to the EduTalk series hosted by Biotone, the Biotone EduPartner School Program, and massage industry experts. With the interest and popularity of the EduTalk series, Biotone continues to support virtual learning and building massage community by connecting you with industry experts who share their knowledge and expertise on topics not only for class discussion, but career success. Today's expert is James Waslaski, an international lecturer, educator, and author of Clinical Massage Therapy, a Structural Approach to Pain Management. He's an approved NCBTMB provider, a certified personal trainer with National Academy of Sports Medicine, plus he teaches weekend seminars with the Center of Pain Management. With over 33 years of experience, James is a 2008 inductee into the Massage Therapy Hall of Fame and was recognized as Teacher of the Year at the 2012 Canadian Massage Conference, and again in 2015 at the World Massage Festival. Let's listen and learn as James discusses integrated manual therapy and orthopedic massage for complicated shoulder conditions. He'll share his techniques, approaches, and structurally oriented routines for immediate and permanent results for rotator cuff injuries, bursitis, pectoralis minor, bicipital tendinosis, rhomboid pain, and thoracic outlet, while reviewing the multiple crush phenomena, how cervical conditions play on weaknesses, numbness, and tingling through the shoulder, arms, and hands, plus share his multi-disciplinary approach for assessment, treatment, and self-care of conditions. And thank you everyone for being so patient. We have a lot to get to. James has an EduTalk full of information, so I'm going to exit the screen. Welcome, James.
Thanks,
And,
Danelle.
and it's all yours. I'll come back on to help you with chat. And everyone, feel free to chat questions and comments during the presentation, which James will answer at the end. Okay, take care.
I want to thank everybody for their patience. And so I want to just have you look at some of the slides. If you look at the second one on the first row, the second one left to right, you're going to see a bunch of nerves coming out of the neck. And anything that's coming from the neck into the clavicle is called the thoracic inlet. So when you look at trapped nerves like carpal tunnel or thoracic outlet, you got to release facet joints and scalenes and clavicle stuff. And so we're going to venture through this now. And I want to talk about the word frozen shoulder. For 30 years, I've been investigating what a frozen shoulder was. And I got to meet my friend and colleague, John Sharkey, in Dublin, Ireland. And this is what he wrote in an article about frozen shoulders. He said, it's a painful condition referred to as adhesive capsulitis. The results require a much larger investigation because a lot of people are telling you stuff that it actually isn't happening to that shoulder. So what he would do is he would dissect the shoulder. So if you had a frozen shoulder where you couldn't move your shoulder when you were alive, he would dissect you. And he found that rarely ever did the patient have a truly frozen shoulder. There was no thermodynamic aspect. It didn't matter if you heated it up or warmed it up. He said he found that a lot of these patients had injured their rotator cuff or had fallen and had minor scar tissue issues. And that's what adhered around the capsule. And so what he said is that motion restriction was a result of anticipation of more pain. Meaning if you take that shoulder and you try to force it, you're only going to make it worse because they're going to do what's called protective muscle guarding. They're going to start to splint the area and they're going to protect you from doing anything more. So what we have to do is, I was just with Eric Dalton's symposium, is a celebration of life. And everything I learned from Eric Dalton over 28 years was we have to change the brain to change the pain. So we cannot be forcing a shoulder to move until we get it healthy enough. And that's what this course is going to talk about. So I want to throw in rib injuries for this too. I want to talk about rib injuries because I broke 6 ribs and I punctured my lung about 3 months ago. And you can see me in the ICU, and then I was using the Bemer mat, and I was using Dolphin microcurrent that I'll be using on my client today, and I'll be running the Bemer mat that got oxygen into the cell tissues. Of course, I had the TLC of my rescue dog at my side. And long story short, is with 6 broken ribs and a punctured lung, I was able to teach with oxygen 2 weeks later in Colorado, and I'm completely healed 3 months later. And I want to walk you through part of that journey. And I want to just say a little bit about the Bemer and what it
How
is.
does it work? Folks, Bemer stimulates muscles. The pulse electromagnetic field from Bemer moves through the area being treated, stimulates the tissues and the cells that the pulse electromagnetic field interacts with. The effect extends through the tissue into the vessels, as you can see on the screen here, supporting healthy local circulation where the field is applied. In addition, Bemer inductively stimulates your muscles in order to increase blood flow and optimize muscle performance, as well as supporting recovery. I want to take a look here at this intravital microscopy video. This is the local microcirculation of a male who's been under chronic stress. And what we're seeing here is a zoomed in view of a local area of microcirculatory vessels. And on the left side of the screen, you're looking at an arteriole that's vertically orientated, and on the right, also oriented vertically, is a venule. The small vessel that is branched off horizontally on the left is a capillary. Arterioles are responsible for bringing oxygen-rich blood into the capillaries, which then deliver the blood and its components to the cells, which are vital for these cells to function. You can see the blood flowing clearly in all the vessels here observed, but the little capillary is not being adequately perfused with blood. Therefore, the cells do not get what they need to work properly. You're going to see here also that there's no vascular movements or oscillations occurring with the arteriole on the left side, which should be. In addition, there's restricted blood flow, there's poor perfusion, and diminished venous return. Too much of this going on, and you're going to feel tired, you're going to feel sluggish, maybe even experiencing cold hands, cold feet. But one thing's for sure, poor blood flow can be the precursor to many issues that people experience every day, and they don't even know it. Let's take a look here what happens to Bemer after it was only turned on for 3 minutes of treatment. You'll already start to see this increase in blood flow. You can see the capillary open up. There's an increased arterial flow. And what you can also see is this increased venular flow, returning carbon dioxide back to the lungs and clearing out the waste products from our body. Here we are after 6 minutes of Bemer use. I want you to pay
So I think what I'll do is you get the idea. Blood flow does everything. It affects the lymphatic system, the immune system. So just a little bit of reason I used that, and I'm going to be using it under Matt today. Improve blood flow, increase oxygen, improve carbon dioxide, stress reduction, improve performance, increased endurance, and faster recovery. So that's what helped me heal an injury that should have taken 3 to 6 months in about 3 to 4 weeks. So I'm also going to be using microcurrent. Here's my using a Dolphin microcurrent on scar tissue. Another old injury I had in 2020. And you can see the second image shows after my leg was sewn up and there was bruising. And within 7 days of microcurrent and lymphatic drainage, you can see the second picture became the third picture. So when we work on that rotator cuff tear, the same thing's happening, but it's inside the shoulder. Can you grab me that shoulder model? And so when you look at, thank you, when you look at a rotator cuff injury, when it's inside of here, all that scar tissue is accumulated down here. So if they have a rotator cuff injury, I'm going to be using the Dolphin microcurrent. Now let's get into the anatomy of the. First thing I'm going to do with Matt when I get him up here in about 10 minutes is I'm going to check his range of motion. And why you want to see how far can you move your shoulder into different motions is tight muscles will restrict motion. So I want to look at different areas of tension. I want to look at what injuries are causing you to not move without pain. I want to look at whether the problem is muscle, bone, ligament, or nerve. And that's what we're going to walk you through in the shoulder. And so I want to talk about the word end feel. If you look at the first slide on the left, I'm trying to stretch my client's subscapularis, but it's not going anywhere. And there's a bone-on-bone like end feel. And what I found when there's a hard infill in the shoulder, which you'll see me when I assess Matt, I'm going to do about a 5-minute assessment and about a 20-minute treatment, is that the movement is restricted inside the joint because of lack of synovial fluid and hyaluronic acid in the shoulder joint. So we'll be looking at that in a few minutes. The other thing I want to do is I want a muscle test. You know, we have 4 rotator cuff muscles. We have the subscap, which rarely gets injured. On the backside, we have the infraspinatus and teres minor that gets weak, inhibited, and full of trigger points. But the one on the top is the one that gets trapped under the acromion, and the supraspinatus usually gets micro tears under there. So we're going to be attesting that most likely the supraspinatus could be injured, on a rare occasion, an injury in the subscap, and on a rare occasion, an injury in infraspinatus teres minor. And we'll be evaluating that before we put Matt on the table. Now, I brought this image in there because when I abduct my shoulder, when I do that, my clavicle, if you look at the clavicle on that image on the left, your clavicle should drop on the inside and go up on the outside. And so sternoclavicular fixations happen. If you look at the lateral part of the clavicle, if you look at the very far left over the acromion, the clavicle literally sits on the acromion. So when the clavicle sits here and the clavicle is not moving when you abduct your shoulder, it creates impingement. I worked on a Major League Baseball player and they were injecting him with corticosteroids. And all I did is got the sternoclavicular scapular motion back by doing one technique, which we'll show you on the table. And all of that impingement went away in that shoulder. The other thing we're looking at is trapped nerves. When you have trapped nerves, you always have to start with the neck. If you look at the 4th image, left to right, you see the scalene muscles. And with the scalenes, in between the intermiddle scalenes, you can see the brachial plexus of nerves. And the thing about scalene muscles is they're not part of thoracic outlet. They're actually cervical muscles, as you can see in this image. So if we don't stretch the scalenes and release the nerves that are trapped in the neck, we can't release the nerves that go under the clavicle, under the pec minor. So to treat carpal tunnel, you've got to treat nerves in the neck and shoulder. In fact, 90% of carpal tunnel pain and nerve-related pain in your wrist is actually starting in your neck and shoulder. And like a garden hose, if it's not flowing through your neck, shoulder, and elbow, wrist, and hand, you can't treat the nerves here if you don't release the nerves in the neck and shoulder. So we'll show you a really good scalene release. And if you notice on the far right image, my fingers are on the first rib. When you take a deep breath, the first rib is going to come up. And when you exhale, you can pull the rib down. And if you don't pull the rib down on exhalation before you move the head, you're not stretching the scalene. So I'm going to demonstrate that to you. Now, the image is here on the far left. You see a picture of the capsule. That's the part that the humeral head sits inside, that white part. And when fluid does not get in that capsule, there's no movement within that joint. And what happens is then your doctor says, well, you can't brush your hair, you can't wash your face, and you can't move your shoulder. And that's because this capsule doesn't have hyaluronic acid and synovial fluid. So we're going to do techniques that pushes fluid into the capsule to free the inside of the shoulder so the movement can happen on the inside and the outside of the shoulder. And then we're going to go into subscap. Again, that hard end field, the far left, we're going to be doing capsule work. And when you try to abduct the shoulder, I'd say about 50% of the population have what's called shoulder impingement. So if you look at the 3rd image, left to right, when I'm raising that shoulder, what's happening is this supraspinatus tendon and this long head of this bicipital tendon that sits under here is being pinched. And impingement means that you're bunching everything up in that shoulder. One of the techniques we're going to show you on the table is we're going to relax those upper traps and that middle deltoid. We're going to find that clavicle. We're going to decompress the humeral head. When we create space in there between the humeral head and the acromion, the bicipital tendon long head and the supraspinatus tendon will no longer be pinching, and we'll see that range of motion come back in that shoulder. And then Vladimir Yonda, a brilliant osteopath that Eric Dalton had studied and then trained me about his work, said the world we live in, working on computers, driving cars, doing massage, pretty much everybody has a tight pec major, a tight pec minor, a tight biceps, a tight subscap because we're rotated medially, we lose lateral rotation. So we're going to be working on pec major, pec minor, and the biceps because the biceps, if these get tight, it drives the tendon up here, and that bicipital tendon pinching or impingement cannot be released if we don't release the muscle belly of the biceps. So a lot of times when somebody does an arm curl and they extend that arm, the extension of that arm drives that humeral head up. And so releasing the biceps can treat impingement of the tendons of the shoulder. One thing I learned from Eric Dalton is we should never stretch pec minor. Pec minor is the most problematic muscle in the front of the shoulder. We should never stretch it until we drop the humeral head. So if you look at the far left image, my hand is pushing down on that humeral head. I'm basically going to be doing a technique where I'm pushing down, not on the acromion because that would create impingement, but on the middle deltoid area, and I'm creating space in here to treat impingement. Once the humeral head can drop, you can stretch out the pec minor, and that can release thoracic outlet and shoulder impingement problems. And we'll show you that in the table treatment in just about 10 minutes. A lot of people underestimate the power of sideline work, the power of lying on your side and doing upper traps and lats and pulling that humeral head down. So we're going to be going from supine to sideline and further of treating the muscles that can restrict motion of the shoulder. I love doing sideline work, so we'll be doing a little bit of that today also. And then this is my favorite technique ever. If you walk away with one technique today, I want it to be this one. My friend in Australia, David Sheehan, said, Jim, if you could only do one technique or give me one PowerPoint with 4 techniques in it, which is this one. He said, what would you do to every patient that ever comes into your office for shoulder problems? And I'm going to slow down on this slide because this is the critical changing point. If you only learn this technique, this is what you'll treat. On the far left, we're reaching under there and we're stretching pec minor. So my finger pads are pulling up underneath your pec minor, and I'm lifting the scapula up on the rib cage. What that does is that frees up the brachial plexus of nerves, it releases the pec minor, and it really pulls that scapula off the rib cage. The second one, from left to right, is I'm relaxing the capsule. I'm pushing in, and when there's scars around the capsule from rotator cuff injuries, by shortening everything in that shoulder, the capsule feels safe and the brain feels safe and the muscles feel like they don't have to guard. So we're going to do a technique that relaxes the capsule and stretches the capsule. So from image 2 to image 3, we're relaxing the capsule and stretching the capsule. And that's pulling in synovial fluid and hyaluronic acid so that there's inner joint movement so that we can better treat the muscles on the outside. On the last image, you're seeing my hand go like this. Once again, oftentimes there's no space in there. So the impingement, we have to create space in there. A lot of doctors will cut the ligaments and shave down the acromion. They shouldn't be doing that because when they cut the ligaments and shave down the acromion, they actually create scar around the supraspinatus, and the scar that the surgery creates then locks the humeral head to the acromion. And now we end up having a worse shoulder than before we actually had before we had surgery. So we want to talk about, I was in Kuwait and Dubai, and the doctor in Dubai is the leading shoulder surgeon in the world. He brought me out there to use the tools I'm going to be using on Matt and a patient, in between microcurrent, vagal nerve to get scar tissue healthy, and these techniques. We had a lady that had a shoulder, she couldn't even brush her teeth or wash her face for 25 years. At the end, she had full range of motion of that shoulder. So in 2018, I was supposed to teach 300 orthopedic surgeons the work that you're going to learn or be introduced to, I should say, in this workshop, because really a live class is more important to learn these and see the pictures and the pathologies. So the other thing we're going to do is when we're doing massage, our scapulars are rotating forward. When we're working on computers, our scapulars are rotating forward under the rib cage. And then when we're doing massage, where we're reaching over, our upper traps are getting tight. So what we're going to do is we're going to relax all the muscles in the back. The muscles in the back also, all that tissue has to be pushed towards the spine. Then we're going to use the scapula. If you look at image number 1, 2, 3, left to right, image 3, the scapulars are usually upward rotated like this. We're going to downward rotate the scapula. We're going to bring it so the medial board of the scapula is closer to the spine. If you look at image 3, when I downward rotate the scapula, it relaxes your rhomboids, it relaxes your levator scapula. All the trigger points behind your scapula go away when you put the scapula back where it belongs. And then again, stretch the capsule. If you have a supraspinatus tear, the first thing we would have done is treated that with microcurrent, which I'll demonstrate briefly on Matt. The second thing we would do is balance all the muscles in the shoulder. As I did, I walked you through the slides. The third thing we'll do is loosen up those upper traps and release the muscle belly of the supraspinatus. And then we'll do a little bit of frictioning to treat the scar and some eccentric loading to create healthy tissue so that I had a 2nd-degree tear of my supraspinatus. And through the work I'm going to be demonstrating and introducing you to tonight, I have full range of motion without surgery because we normalized the scar tissue with microcurrent. We balanced out the rotator cuff muscles. We increased space so that the supraspinatus wouldn't get re-injured in there. And it's pretty amazing what we can do in the world of manual therapy. And then the other thing is, because our shoulders are forward all the time, our rhomboids, our muscles in our back, they're always locked to long and they go weak. So when you go to the gym and you try to strengthen your rhomboids, they can only fire about 20% of their potential. So the other thing we're going to do is we're actually going to take put the muscles on a stretch and do what I learned from Dr. Eric Dalton. We're going to do fast-paced spindle cell work. It's going to affect the spindle cells and the Golgi tendon organs, and it's going to really wake up the muscles in the back. And I want to give you a piece of advice before we get into the exercise part. Please never stretch this way at all. Never stretch this way because you're shortening your pec minor, you're trapping your nerves of your shoulder, you're driving the humeral head forward of the chromium. And this is the worst stretch people can do for shoulders. Really, we need to be stretching that shoulder back and we need to be strengthening the muscles in the back because what that does is that puts the humeral head back into a state of balance. So once you roll the humeral head forward by pulling your shoulder forward, you have a bad shoulder. So if you're doing this stretch, please stop, just stretch the muscles in the front and strengthen the muscles in the back, which the last slide will kind of show you. Fran is stretching her pec minor in the front. She's using a Velcro glove to let her humeral head up, and she's strengthening her rhomboids in the back. So with that, I'm going to go to the full screen here and do the stop share right here. And we're going to go full screen. And Danelle, are you able to do a different screen view? Let me see if I can do it on my camera. Speaker. There we go. And Danelle, I see you on the big screen. Is there any way to do a different screen view? Speaker, multi-speaker. Let me go. I'm trying to.
James, what are you trying to
I'm
set
trying
up?
to go big. We're on the big screen right now. I see you on the big screen. I'm trying to get where I'm actually on the big screen.
Then it's go up to the view,
Got it?
and at the bottom it should say full screen.
It says exit full screen on the bottom.
Oh,
Speaker. So when you're not in there, do you see me on the big screen now?
someone from the audience says you are on full screen.
Okay, then I can do that. I've got a little backup screen, so I'm going to move this a little bit. Matt, can you move that table just a little bit closer to us? So we're going to do a little assessment with Matt. And I am on the big screen, so Matt's just going to walk in front of this table for a moment. And what we're going to do with Matt is we're going to check his abduction. And we're seeing that that's all bunched up. That's an impinged shoulder. So what I usually do when I see that is I take this model out and I show Matt that it's all bunched up. I need to drop the humeral head. Also with Matt, we're going to check his supraspinatus tendon. So if I put his arm out like this and I push in, Matt resists me, and the pain's right here, correct? So Matt's got a tear in the supraspinatus tendon. In a longer course, we'd check all the muscles because and then I want to check your clavicle. If you want to take your shirt off for a second, please. So when I look at Matt's clavicle, here's the clavicle, put your palm forward. When you abduct the shoulder, your clavicle's not moving. So the clavicle's not moving, and do that again. And since the clavicle's not moving, we have to release the sternoclavicular ligament, and then we have to drop the humeral head. And we're going to be treating, for the sake of the camera, we're going to be treating this shoulder. So let's go to this side, and we'll step this way. Here we've got limited clavicular motion. We've got an elevated humeral head. We're going to treat the clavicle. We're going to treat the pecs. We're going to treat the scalenes. We're going to drop the humeral head. So I'm going to have you lie face up. And while Matt's getting on the table, I want to bring that closer. I'm going to show you basically the Bemer machine, and I'm going to be running this in the background. I talked about that in a little bit on the presentation. And let's move this table really close to the computer. Listen to this. So we're going to move Matt really close to the screen. And the first thing we're going to do, and I'm going to get this camera zoomed in so you can see Matt really good here. We're going to go here. And we're going to see we've got all good shot of Matt. And we want to look at this clavicle first. So the clavicle is a bone that when you abduct that shoulder, when you abduct the shoulder, this bone should elevate. But when it's locked at the sternal articulation, it's actually impinging the acromion. So what we've got with Matt is we've got impingement of the acromion, and we have to treat the clavicle first. So I'm going to step around and do that first. So when I treat the sternoclavicular joint, I basically take 2 fingers under the clavicle and I move the clavicle towards the sternum to relax the sternoclavicular ligament. And then what that does, Matt, I want to show you when you slowly watch out for the ladder, slowly abduct your shoulder, you can see his clavicle moving, come on back down. And you can see that the clavicle's moving. So I'm going to repeat that technique one more time. All I did is I found the bottom of the clavicle. I held under the sternoclavicular joint. I put this in Matt's opposite pocket. That relaxes the sternoclavicular ligament. And a lot of people don't treat that because if this clavicle is not lifting on this end and dropping on this end, it's causing shoulder impingement. So again, when you abduct your shoulder, Matt, the clavicle's moving just fine. So we've treated that. Now, the next thing we're going to do is we're going to treat some of the muscles of the shoulder. The muscles of the shoulder that we're going to treat are pec major, pec minor, upper traps, middle deltoid. So I'm going to get in here and I'm going to use some of the magnesium calming cream. Magnesium deficiency causes a lot of nerve pain and muscle spasm and associated nerve pain. So the first thing I do is I just want to warm up this pec major. I'm going to come down with this table a little bit. Yeah. Warm up the pec major and stretch those fibers out a little bit. And then I'm going to do pec minor. I'm going to just walk around this. For pec minor, you have to go from ribs 3, 4, 5, and 6 to the coracoid process. So I'm just loosening up pec minor. This is probably the most important muscle to treat. Probably pec minor is the most problematic muscle in front of the shoulder. You can get into subclavius too in that area and get that pec minor released in there. And then what we're going to do before we, the supraspinatus is injured. So there's scar tissue under here. So what I'm going to do is create space to get pressure off that injured supraspinatus. Then I'm going to take the microcurrent and I'm going to treat around the scar that's formed because that scar under there was what's locked that shoulder into place. So what I'm going to do with Matt is I'm going to work this middle deltoid, this one right here. Just work middle deltoid. And then what I'm going to do is I'm going to lock the elbow straight. So here's the middle deltoid with the elbow locked so it can't move. And I'm going to do a different position so you can see this. Okay. Let me turn the table long ways. So I want you to be able to see this because it's a critically important technique. So when I come into the middle deltoid area, I lock the elbow and I push straight down on the humeral head. What that does is that unlocks that supraspinatus tendon. And so now that I have space between the acromion and the injured supraspinatus tendon, and I won't do the full treatment with the dolphin MPS microcurrent, but I will tell you what I would do. This treats the scar at a cellular level. So I'm just going to shut the volume off. And I'm going to treat right around the acromion. So when there's scar tissue under there, you can't really get your fingers under there to create friction. So you hold the buttons like a writing pen and you treat it. And you can go to the Dolphin MPS website. It'll talk about all the science behind the scar tissue. And so we're running the microcurrent back into here. We're treating where the scar is. Sometimes it'll be injured out here. So you just treat that with Dolphin microcurrent. And what that does, unlike frictioning, unlike scraping tools, unlike Washa or Graston, it treats the scar at a cellular level, where if you do scraping or frictioning, you're just treating it at a physical level. So I find that long-term frozen shoulders are injured rotator cuff muscles that have thickened and that have glued all the structures together. So what that shows you is that typically any scars in here, that humeral head is now adhered or scarred to the acromion. And that's why these people can't raise their shoulder. That's why they're kind of going like, I can't brush my teeth, I can't wash my hair. It's not really a frozen shoulder, it's scar tissue that's accumulated around the shoulder area. So the next technique I'm going to bring Matt towards the camera. And we're going to have you go sideline on your left side down, buddy. Thank you. Side down. I'm sorry, right side down. So why I like sideline work is if you look at Matt's rotation of his shoulder, there's a bone-on-bone like end fill. That bone-on-bone like end fill is a lack of synovial fluid and hyaluronic acid in the shoulder space in the capsule. So between the scar that's wrapping around and the lack of synovial fluid and hyaluronic acid in the joint space, most doctors will say you have a frozen shoulder. In fact, what cracks me up, Matt, is sometimes they'll say it thaws out in 6 months to a year. It's not frozen and it cannot thaw out. There could be an emotional component, there could be an energetic component, there could be a nutritional component, but there is no thaw, there is no such thing as a frozen shoulder that thaws out. So we have to be careful what we tell our patients. So sometimes let's put this under your head and neck, buddy. And then we're going to do a little upper trapezius work. I think for the sake of the camera, I'm going to bring this down just a little bit. I'm just going to do a little myofascial work here, lifting up all this tissue, do a little middle deltoid work. Sometimes you just got to get those upper traps to relax, get this tissue in here nice and warmed up. And the reason I'm doing this is I want the humeral head to drop off the acromion more. Little middle deltoid work. I'll probably do a little bit of lat work. So I just kind of come back in here. Whatever lat work you want to do is good. And hook that tissue. And then when we go to stretch subscap, we can't. So this is my second favorite shoulder technique of anything that I ever do. So I want you to watch this one closely. When you have a hard infill and you just can't stretch that subscap, you hold the arm and let them relax the shoulder. You then shorten the capsule. So you're shortening the space. What this does is this lets the brain feel safe. And then the rocking or the trigger, this calms down the secondary muscle guarding. It tells the nervous system, hey, I'm gonna like, and you can feel the change in breath. Part of that's because he's on the Bemer mat, increasing oxygen levels at the micro blood vessel level at 27%. Part of it's the vagal nerve stimulation and changing in from sympathetic to parasympathetic stress. And part of it's the trigger. Now watch this transition. I'm going to put my hand here. I'm going to stay off the shoulder. I'm going to decompress the humeral head. This increases synovial fluid and hyaluronic acid. So as I do that, I'm basically pumping in synovial fluid and hyaluronic acid to the inner joint space. I'm also, by pulling that humeral head down, I'm creating space under the acromion. Remember the impingement where the supraspinatus was injured. And I don't usually teach this fast. This is like me on super high caffeinated speed. But the reason I'm doing this, I want to get a lot done in the 20 minutes I'm allowed. A class time, this would be a 6 to 8 hour class. So I'm going to relax the capsule. For hands-on, it would be a 6 to 8 hour class, but I'm doing real-time therapy. So now watch Matt's rotation. Now Matt's got, I can stretch his pecs, lats and subscap. Now he's got 90 degrees of external rotation of the shoulder. So we have full range of motion back. All these muscles are lengthened. Never treat the back until you release all these muscles in the front. There's no exception to that because of the way the world we live in. And then Matt, we're going to go face down. I'm going to move this just to sneak through here. And then we'll move you back to the camera. Okay. Now this is my all-time favorite technique on this shoulder. If you can only do one technique, I'm going to slow this down so that when you watch the video, this technique will be the one you're going to remember the most. Pretty much everybody's scapula is pushed into the rib cage, so it's adhered. I'm going to actually use the other shoulder to demonstrate this. Pretty much the scapula is locked in the rib cage, tight pec minor, tight upper traps, and it's upward rotated. So on that shoulder, basically, I want to take that scapula and I want to drive it back this way. I want to take it back. I want to pull the scapula down so that it shortens the rhomboids and it stretches the traps, and then it gives me more space under the acromion. So when I go here on the shoulder I'm working on a mat, nice relaxed hand on the upper traps. My other hand's going to be on the border of the scapula. So I'm going to go on the border of the scapula, and it's way up here. See Matt's scapula? It's way up here. These rhomboids are locked long, levators locked long, lots of trigger points in here. But if I lift pec minor and slowly rotate this down to the spine, lift, stretch pec minor, stretch upper traps. And I'm going to show it on the other side just because I want you to see the visual. So when you're in my workshops, I'm using a lot of teaching tools. This is where his scapula is, and this is where it belongs. Pec minor's tight, upper traps are tight, rhomboids are weak, serratus anterior goes weak, the scapula goes out like this. So if we push the scapula back, lift it up at the front and drag it down, so it would look like this on the other side. Pick it up and drag it down. Pick it up and drag it down. What that does is that relaxes his rhomboids, that relaxes his levator scapula. And then what we can do, and I'll just stay on this side for the demo, I would obviously just treat that shoulder, but once I put the scapula back where it belongs, which shortens the rhomboids and loosens up the levator scapula, then what I do is I go under here, stretch pec minor, that's the troublemaker, so nice flat hands, stretch pec minor, and then go here and relax the capsule, stretch the capsule. So what I'm doing is I'm shortening the capsule and pulling in fluid, shortening and pulling in hyaluronic fluid. And then my most important thing is to increase subacromial space. So as I relax the capsule and stretch the capsule, relax the capsule and stretch the capsule, that allows me to increase subacromial space. And then Matt will feel his shoulder completely freed up from the rib cage, completely freed up from that rib cage. Now I'm going to go back to the shoulder I was actually working on so I can completely treat Matt's left shoulder. So I'll repeat that on this side. I do this bilateral, stretch pec minor, relax the capsule, pull in synovial fluid, relax the capsule, pull in synovial fluid, drop the humeral head off the acromion, feel how free that is in between there. And then what we're going to do is, now what have we treated? Pec minor related thoracic outlet, supraspinatus impingement, bicipital tendon impingement. We've got synovial fluid going into the joint capsule. So I'll do that one more time. Favorite one, I'll slow it down. Pec minor, 1001, 1002. Relax the capsule, stretch the capsule. This is bringing in synovial fluid and hyaluronic acid. Drop the humeral head off the acromion and feel how free that is. Then we just put the scapula back where it belongs. Do you notice I haven't treated his rhomboids? And by now, people would say, when are you going to treat those trigger points in the rhomboids? And I'm not going to do that yet because all this tissue is locked long. So with all this long locked tissue, I'm going to take the magnesium calming cream, and I'm going to take everything from Matt's triceps to a state of relaxation towards the shoulder. Push that tissue back where it belongs. Since this is all locked long from forward shoulders, we're going to drive relaxing the spinatus and teres minor. We're going to relax the rhomboids, the middle trapezius. We're going to push the erector spinae into the groove and drive it down the lamina groove. And we're going to just move through that area. And then if you've ever studied with Eric Dalton, we just did a tribute to his life in Oklahoma last weekend. There were about 150 people there. He would always take his ulna and drive the tissue this way. Because if you can push everything back up into the spine, you can do better spinal biomechanics. If you can rotate everything back into the spine, so go that way, take your ulna, drive it down the lamina groove. And if we have any fixated facet joints or rib heads, once these tissues are this way, once the tissues that are locked long are shortened, we can do a little oscillation to check out those rib heads. get those ribs springing a little bit. And we can also do some, check the lamina groove at the end. I treated a gentleman today that had, he was approved by his oncologist. He had cancer in his spine and had so much pain in here because the spine had rotation and side bending. And as soon as we treated his rib heads and his lamina groove, which is part of the shoulder problem, he felt amazing. So I'm just going to use my thenar eminence. And as I push in, I create a little twist. I call this the Texas twister since I live in Texas. And we just rotate the spine a little bit. But everything needs to be driven medial. Everything, all this tissue needs to come back to the spine. So we need to move everything back into that lamina groove. And then we check the lamina groove, facet joint and rib head problems here, facet joint issues here. So for facet joints, you take your thenar eminence and you just do some gentle compression and side bending. But stay off the spinous processes, never press on the spinous processes, always being the lamina groove. Okay. And then the last thing I'm going to do with Matt, I think that Michael Phelps probably made this famous when he was winning all his gold medals swimming. But if you were a swimmer, Matt, and you had to come out like you're going to do the butterfly, this has to be functional. So with weak rhomboids, when those swimmers stretch across the front, these go long and weak. So with Matt, we're shortening, but we have to activate the rhomboids. So to activate the rhomboids, I just put his shoulder on a stretch. And I'll show it the way I learned it from Eric Dalton. He would go and he would do really fast-paced spindle cell work. And all of his teachers now do this fast-paced spindle cell work. It's affecting the Golgi tendon organs. It's called the dynamic gamma motor and neuron technique. It's affecting the muscle spindle cells. It's got to be on a stretch. But because I'm getting to be middle-aged as I turn 69 next week, I don't want to spend that much energy. I want to apply vibration, percussion, and approximation. I want to just hook that tissue. This is the mild body. I can drive the erector spinae back into the groove. You can treat as levator and upper traps, but mostly this is to stimulate weak posterior rotator cuff muscles, weak rhomboids, and it wakes up the nervous system. So if you do muscle spindle cell Golgi tendon organ work to the back, you stimulate and the brain now sends a 60% stronger message to these muscles to fire. So now when we recheck his horizontal abduction, now come out of the water like come as high as you can see that there's a lot more power. So with that being said, I'm going to go back to the other screen and go into some Q&As, and you can go ahead and take a look and say hi to the crowd, Matt, and say hi, and we'll bring you in on the closing.
Thanks for having me as a model.
You bet, buddy. We're going to rotate this back over. Thank you. Now I want to admit that was fast and furious.
Awesome.
I'm just going to come out of this screen share. Let's see. All right. I just shared. Let's go. Danelle, can you come back into the other screen? There we go. That might pull me back in. Let me get rid of this slide. Are we back? Both of them?
No, you may have to hit the share button again.
Okay, let's do that. Oh, I see. Stop share. There it is. Okay, now we're back.
You did stop share.
Yep.
Okay.
We're good?
Yes.
All right, let me go down here. Okay. First, I want to thank you for the glitches at the end, for your patience with that. I want to apologize for a few of the little glitches. I teach 45 weekends a year around the globe, and I'm a perfectionist. So this didn't go to my expectations, but I think at least I got the point across. And I really appreciate being part of the Biotone series talks. And I've known Donnell forever, and I've been really honored to be a friend and to be involved in these talks. And I appreciate everybody online. I really appreciate you all joining me to introduce you to this shoulder work.
Well, thank you so much. And thank you for, it was a very detailed and informative EduTalk. And I'm with Laura, who said she wished she was in Matt's position right now, laying on your table. So that was great. I almost felt like I could feel your hands on my back as well.
Well, that's
So,
thank you, Laura.
yes. Let's see. Janice had some questions about the dolphin,
Uh-huh.
asking, why do you need two?
So Janet, there's a negative polarity and a positive polarity on here. And in order to get the energy and the ATP, so here's an example. I had Mohs surgery here about a few months ago, and I had a big hole like this on my forehead, but you can't see it. So when the stitches were in there, I would just start to treat the scar tissue. Look like Mickey Mouse, don't I? I would start to treat the scar tissue, and I would work around that scar. And what it did is it put the energy in the ATP. The reason you need two is you got to go positive to negative on the polarity of the microcurrent. And it brings in energy, ATP, and cell metabolism. So as you can see with my tissues, it makes the skin normal again. It makes, like when I had a hip replacement, it made that tissue normal again. And when I had a rotator cuff injury, it makes that tissue healthy and normal again. But you do need two because you got to go positive to negative.
And Janice is asking, can you use these techniques on clients who have had shoulder or collarbone surgery?
So that's funny you ask, because just today, this morning, I had a lady, she had breast reconstruction from cancer. She had two reverse shoulders. She had two reverse, one 2 years ago, one this year. And this is going to give me goosebumps. So as we opened up the scars, we did a lot of microcurrent and scar tissue work for the reverse shoulders and the sternum. So she was able to pull her shoulders back, wash her hair, brush her teeth, wash her face, and move up like this. And that was one treatment. So absolutely, she had a reverse shoulder repair. Minor stuff like a supraspinatus shoulder repair, you must do it. And in most cases, like I had a second-degree tear of my supraspinatus, in most cases, you can prevent them from having surgery if you do this work.
All right. And Lori is asking, do state massage boards typically allow the Bemer and Dolphin to be used by massage therapists?
It's state by state, and I know in Florida we definitely can, and I know I'm licensed in Florida and Texas. I would say about half the states in the United States are currently approved because they're proven safe for anything. Dr. Bruce has done a million treatments, even with people with pacemakers. The difference between microcurrent and TENS units aren't safe. They're alternating current. They can affect with defibrillators and pacemakers. TENS units, let me compare it. It'd be like sticking my finger in that light bulb and my muscles start twitching. So TENS units aren't necessarily safe if you look at the research, but microcurrent and Bemer is. And if your state does not approve it, email my office staff, and the developer of those units, the developer of the Bemer and the microcurrent, will work with your state board and help you show the safety to the patient and help you get it approved in your state.
Great. Well, we have some thank yous coming in. Haven't seen any new questions come in. Everyone, you still have a few minutes to submit questions. But James, during this time, and again, thank you for this presentation. Why don't you tell us here's one. Is the microcurrent similar to magnet work?
No, they're very different. Magnet will work with the polarities, but the microcurrent, the scientific research says that it increases energy, ATP, and cell metabolism. So if you really want to treat the cells and make them normal again, give them back their energy, their ATP and cell metabolism, obviously there's energy everywhere, energetic work, but I think there's a very unique difference between microcurrent and that. So I'm just a big guy for microcurrent and vagal nerve stimulation and Bemer circulation stuff. That's what helped my 6 ribs and punctured lung heal in about 2 months, or actually I was teaching 8 days after that injury because of that type of technology.
And your scar and your knee issues. You're like the bionic man. Laura is asking, is microcurrent similar to red light therapy?
That's funny because my wife just showed it. Microcurrent is microcell position. There are so many mini vascular structures that don't get blood and oxygen. And red light therapy is uniquely different. I know my wife just yesterday Googled microcurrent and red light therapy. Do you want to send Fran back here for a second? Yeah. As we answer a couple more questions, she just looked that up. So I'm going to bring my wife back to answer that question because she just looked that up yesterday, and I'm going to bring her back here for a minute.
While we're waiting, I'd like you to mention your Italy workshop.
Okay.
And this will be included in tomorrow's follow-up email, which I'm stealing your time, but tomorrow midday, you should receive an email with a copy of the recording, a handout from James, links to his previous EduTalks in the archive library on biotone.com, and also a link to more information about the Italy workshop. But you have the stage right now.
So the reason we did the Italy retreats, we started it a few years ago. We capped it at 30 to 40 people. When my good friend Eric Dalton, when his wife died tragically and unexpectedly about 5 years ago, I thought that could be my wife. And my wife's Italian, so we wrote our bucket list. And we have a lady named Linda Beach. She used to own a school in South Carolina. She's been a therapist. She goes to Italy for about a month and finds the best villas, the best castles, the best tours, the best wineries. So twice a year, we do Italy trips, and we just got back from Madrid, Spain. We just did Seville, Spain. And we're going to be doing these international retreats every year until I'm not healthy enough to do it, which I hope to be in my 80s doing these retreats. So if you get on the list, she'll send you the way to click in. And the other thing is we have seminars every weekend, and we have all of our stuff on USB and DVDs, and everything is 30% off, and Danelle will be sending you something to get that discount. But the retreats are beautiful to know, because you know how when we go to the conference and people have dinners and they laugh and they joke and they build friendships and camaraderie. Well, the Italy trips are like that. My wife and I spend time with everybody for 7 days, all the dinners together, all the retreats together, and we build friendships that last for a lifetime. So I hope that you take the time to log in and join us in Italy or Spain or Portugal or whatever we're doing next year, mostly Italy.
Okay. Well, that's good. And that will again be in the follow-up email tomorrow. If you do not see it in your inbox, please check your spam or junk folder. And James, I'm afraid if Fran doesn't get in the room in 1 minute,
She's okay.
we're
She's
going to
gonna
wrap
wait.
it up.
We'll send you an email on the red light version.
Okay, and then I'll send it out to the
We'll send you an
RSVP
email.
list.
I'll make sure we send that to you so we can get you the specific research.
That will be great. Well, you did an amazing job tonight through all the technical issues and shared great information. I mean, again, I'm with Lori that wanted to be on the table instead of Matt. So
With that being said, could I just have Matt just say 1 or 2 words just about himself? He's also a very prominent therapist.
Yes, thank you so much for having me, Biotone. I've been doing James's work for over 10 years, and it is a staple for my shoulder, cervical, thoracic work, and grateful to you. So thank you for being the bionic man that you are. I'm the inventor of the Scar Pro, and scar tissue and ribs are pretty much my specialty. I do advanced medical and orthopedic manual therapy, and thanks for having me.
Thank you, buddy.
well, great. Well, thank you so much once again. Thank you, everyone, for hanging in there with us and listening to James's presentation. Join us again. In fact, on August 5th, we will have an introduction to gua sha by Jane Irving. And then for those of you who are aware of our EduTalk Diabetes series, and they're great talks in the archive library, for everyone. You don't have to be diabetic to really gain some knowledge. The diabetes series will present on August 12th with Jennifer Pressimone, Dementia and Type 3 Diabetes, Holistic Sense to Brain and Emotional Wellness. And Jennifer is a past presenter as well on aromatherapy. Her recordings are also in the archive library on biotone.com. And with that, you can relax now. Thank you so much. Thank you, everyone. Be safe. Join us again. Thank you, Matt. And take care. And many thank yous have come in.
Hope to see you in a future workshop. God bless. Have a great evening. Thank you very much.
All right. Take care, everyone. Bye.